You're working in hand therapy. Here are 5 risk diagnoses that I think are really important for you to wrap your head around and be able to think through these types of cases so that you can treat and get great results for your patients. My name is Wong. I'm an occupational therapist and certified hand therapist. If this is your first time here, welcome. Thank you for watching. Keep watching. There's a lot that I'm going to share today in terms of these 5 diagnoses. Over 10 years ago, I started my therapy clinic, and over 5 years ago, I started Hand Therapy Secrets just to share what I know clinically and also to help you think about all the choices you can have in your career as an occupational therapist, and especially anyone who wants to do hand therapy. So here are my 5 diagnoses I think are really important to get your head wrapped around and start to learn about. Distal radius fractures, TFCC injuries, tendinitis. So tendinitis is a really big general topic, but we can break tendinitis up into like radial sided type of wrist pain and then ulnar sided types of wrist pain. But radial tendinitis types of wrist pain can fall under like Decker-Vein's tendinitis. I know a lot of times people think it's the thumb, but it's actually because it crosses right there at the wrist. It is the thumb and the wrist. So just kind of keep that in mind. And then ulnar-sided wrist pain is generally you might see words like ECU tendinitis. So it's extensor carpi ulnaris type of tendinitis. And then we have your typical sprain and strain types of issues. And then the 5th one are ligament injuries like a SL ligament tear. S is scaphoid, L is lunate, and then you have a tear. So let's kind of dive a little bit into that and kind of think about like what you need to know from like how can I start to treat that. I talk a lot about my fast track framework, which kind of goes over bones, muscles and tendons, ligament issues, nerve issues, and skin and fascia. And skin and fascia has to do with like when you have surgeries and things like that. So when we're talking about distal radius fractures are one of the most common fractures of the wrist, right? And I don't want you to be scared just because you see someone has a distal radius fracture. Every kind of injury has a generalized protocol. And if you have a fracture, and it is not stable, then usually they're immobilized for about 4 weeks, 4 to 6 weeks, depending on their severity. And then you're allowed to start moving. But remember, when the wrist is broken, you still need to move the fingers and the thumb. So if you have somebody and they're immobilized, don't forget that there are other things that you can do, right? If you are displaced, you have a fracture and it's displaced, or it's not stable, then what happens is they do surgery to stabilize that. And then once they're stabilized, you can start doing active motion. Now, everyone's protocol can be a little bit different. So some surgeons want them to be immobilized for a lot longer because they're like, therapists are so aggressive. And then some surgeons are like, I've stabilized the surgery, I've stabilized the fractures, you're free to move them because my surgery is so good. And that's okay. Like, they're both right. I've worked with both types of surgeons, and I think that partly you have to understand the dynamic of the fracture so that you can understand how to speak to both types of people to get what you need to get so that you can get your patients started if you get them early. So understand the type of fracture, the severity, and that kind of stuff so that you can know, hey, I should be able to move this person at X time, right? So you need stability. Once you're stable, you're allowed to move. So if someone has stability, you can move someone as fast as 5 to 7 days, right? And movement is graded, meaning just because you move someone doesn't mean you have to move them aggressively. You can move them very gently. I used to work with a hand surgeon who let me do the post-op, takedown. So at day 5 or 7, I would take down the bulky dressing. We would do a gentle, cleaning, nothing crazy, nothing wet, just, kind of clean the wound if there was any blood around it. We would lightly wrap it up, and then we would splint them, and then they would start doing active range of motion with their fingers. And then we would do, this is, if your elbow is up like this, you are gravity eliminated, right? So we just drop it down, and then we just try to pull it back. So very gentle, right? But you're allowed to start actively moving it really nice and easy. Nothing passive, nothing crazy. But then you would move from that into, having the x-rays done and seeing like, hey, there's a certain amount of clinical healing here. And it usually happens between 4 and 6 weeks. And then after that, you can start to do more active range of motion and do more passive range of motion. So just kind of keep in mind those types of protocols. And we're going to go a lot more into details in terms of protocols, how to progress and provide treatments when we're working with hand types of like fractures and wrist fractures and wrist types of injuries. So it's the mentorship program in the month of August. We're going to dive into all types of wrist injuries. So I'm going to leave the link below if you're interested in learning more about wrist injuries and how to progress somebody and treatment ideas that work to get your patients moving better and faster. The link is below, okay? So just to rate this now, TFCCs fall under ligament types of issues. Remember I said the fast track framework is bones, muscles, and tendons, and ligaments, right? So TFCC is a ligament type of issue. And of course, just like with fractures, there's a graded spectrum of the severity. Now, sometimes people have a TFCC injury, means they have little tears in their ligaments, and they're immobilized for a certain period of time. Now, ligaments hold bone and bone together. And ligaments give the joint structure. It gives it stability. So what happens when you lose stability? You have to regain it back. So how do you regain it back if you don't have surgery? You regain the stability back by immobilizing and stiffening it. So you're essentially using the body's own mechanism of healing, which is to stiffen up and to scar down. And then after that, you start to move. So the key thing when it comes to working with anyone with a ligament issue like a TFCC is that you want to increase range of motion and strengthening without pain, because pain equals instability for the most part, give or take. Okay. Can't go into like a full-on 3-day lecture, but that's essentially the gist of it, right? So TFCCs can be between like, oh, I have a small tear to I had a really big tear and I had to have surgery, right? So the protocols for those various types can totally be different. If you had a TFCC repair, right? Repair and a debridement. So those two words are completely different. A repair means they have to pin you, sew some shit together, and immobilize for a certain period of time. So usually the general rule of thumb is 4 to 6 weeks. So ligaments, because they provide stability, they need to be immobilized for a little bit longer than you would probably like a fracture or something like that, right? So if you had a repair, you'll tend to find that your patients were pinned, immobilized for quite some time. And then once the pin is removed, then you can start your therapy. Now, if someone had a debridement, the word debridement just means they went in there, cleaned it up, and that was it. And depending on what part of your TFCC was, your patient's TFCC was torn, that's all you can do. You don't really want to cut into certain parts of the TFCC because there's no there's like less blood supply and stuff like that. So again, just understand TFCC injuries, understand their protocols. Don't be scared to work with them. Just know that you have to know how to evaluate your people and know how to do some clinical testing. So I encourage you to do that when you get like those types of injuries. They're not scary. You just have to, crack open a book, join a program, learn a little bit more about it, and then learn what you're allowed to do and what you're not allowed to do. But from the evaluation is what helps you to determine what you're allowed to do and what you're not allowed to do. All right. Number 3 is tendinitises. Tendinitises should have and we do have it as its own topic because tendinitis is very pervasive, right? Meaning it's chronic. It kind of comes whenever, and it usually comes way before people start to realize they have tendinitis, and they can have tendinitis for tons of different reasons. For example, I'll give you one of my things. When someone comes to me with Decker veins tendinitis, the history, the body type, the the symptoms, like when and how long, all play a role in terms of how I might look at it and treat it, right? And I always look at two things: the tendon, the muscle and tendon, because it's a muscle tendon type of issue. But the other thing that I look at when we're talking about fast track framework is nerves, because there's a nerve that runs right by that area. And so you want to learn how to differentiate, because you don't want to just take on the order, like the doctor writes an order and it's like OT, PT, eval, and treat, wrist pain or tendonitis or Decker vein tendonitis. You always want to confirm or deny that diagnosis, because that allows you to treat better and it allows you to problem solve and understand why that person has that problem in the first place. So you might tend to see it in people who are loosey goosey, which I say loosey goosey, but that just means hypermobility. So moms, right? New moms tend to develop Decker veins because of their baby. Why do they have that? They get that because their hormones are to tell the ligaments to loosen up so the baby can pass through the vaginal canal, right? So the pelvis can separate. Well, it's not just those cells going to that ligament, it's going to all of the body's ligaments. And so new moms tend to become, if they were hypermobile before, they will be even more hypermobile. And so you can sit there and rub on someone's thumb all you want. You can be like, oh, let's put a splint on it, let's tape it. But there's a fundamental reason why they got that in the first place. And when you address that, you will be able to really fully address their problem and be able to get rid of it for like from a long-term perspective. One of the things that I do with my tendonitis patients, I focus on strengthening. I don't do a ton of splinting for these people. I just think you can use a splint if their pain is severe, right? But I'm not a big fan of immobilizing something that has movement. So I had all types of problems when I was a new mom as well. And I guess from my perspective, I'm like, you're a new mom, you have to grab your babies and shit like that, and like you can't even hold them with all these splints, you know what I'm saying? And then I wouldn't want to be thinking about wearing my splints forever. Like, when are you going to get rid of these things? How am I supposed to wear this for the rest of my life? Your patients are asking those questions, and if they're not asking them to you, they're thinking it. So get ahead of the problem. But one of my biggest things is to understand why they have that problem. Because when someone has a tendonitis, right, a muscle tendon issue, or it might be a nerve issue, like a nerve traction, nerve tension, nerve compression type of issue, if you're treating it incorrectly, you're not going to get results. Right? You're just not going to get results for your patients. So again, it's a really big topic. And I go a lot more in depth in my mentorship program. But if you're in hand therapy, or they're starting out, or you've been in it for a while and you're just looking to learn, tendonitis is one of the biggest things. I think there's going to be more and more people coming in with various types of tendonitis, and they always look different. They never look exactly the same, and that's the problem where I think most therapists struggle with, because we're so taught to be inside this box and treat it this way only. And I think if you're watching still for 15 minutes, if you're watching still, learn how to really treat this. It's a game changer for you. You're going to get such better results for your patients when you have the ability to think outside the box, be willing to look outside the box, which sometimes is hard, because you're like, someone told me, she was like, well, I didn't know what I didn't know. But your curiosity got you looking, right? So that's all we're looking for, your curiosity to say, the thing that I've done in the past and the thing that I've watched other therapists in my clinic do just not working. Your curiosity will help you to keep looking for other solutions. But that's number 3 in terms of major risk diagnosis that you want to learn how to treat well. Sprain and strains. Usually those people fall, they twist, there's something happened that was very jarring. It's an acute problem, but at the end of the day is a ligament issue. So sprain and strains it disrupts the ligaments. The ligaments hold bone and bone together and give stability. And you can have sprain and strains in any joint essentially, but you can have it in the wrist. Now, here's the thing that ties sprain and strains to ligament tears, which I'm going to talk about next, right? But sprain and strains are essentially ligament issues that then can become tendonitis issues when they become chronic. So when you're evaluating your patients, really understand date of injury, right? Really understand what they've done since the date of injury. Were they wearing a splint? Were they exercising? What were they doing, right? What clinical tests were done? Because there's x-rays, MRIs, and all that stuff, but what clinical tests have you done to confirm or deny that ligaments are not torn, right? Ligaments are providing a certain amount of stability, right? That's your job as a therapist. You're looking for, are the ligaments providing stability? And then you're going to test against muscles and tendons and say which ones are irritated, which ones are not moving really well. Sprain and strains need to be immobilized, but really honestly immobilized for a much shorter time than you think. You should be your patient should be in a splint for like 2 weeks. And then you want to, if nothing is torn, right, and their pain calms down and you see good motion, they should be out of their splint and doing more progressive movements, right? That's the only way you're going to see if they're able to, one, get the recovery, but two, keep the recovery. So sprain and strains, again, they're a little bit more challenging. They're a little bit more difficult because it requires you to really understand ligaments and how to test for them. But they're similar to tendinitises in the sense that you want to get motion and you want to get movement, but you don't want to do any of those things with pain. Right? So that whole no pain, no gain really doesn't necessarily work for those two diagnoses, right? So just keep in mind, you don't need to splint them for as long as they are, and think about weeding them out of that splint and discharging and getting them moving, okay? Those are some 4 key diagnoses. And my last one is ligament tears. So one of the most common tears in the wrist, in the carpal bones, is between the scaphoid and the lunate. So if you're going to study anything, go study that shit right there. It is one of the more common ones. You want to learn how to clinically test for it, which requires you to be able to manually find the scaphoid and the lunate, and the lunate and the triquetrum, and so that you can test against it. Ligaments hold bone and bone together and give wrist stability. So not only do you have to learn how to clinically test for it, number 2, you have to test it against the other side, right? So I am a very hypermobile person, so I'm very careful when I'm teaching my manual therapy classes. I don't like people to, like, even when I'm teaching my therapists, I'm very careful with how much someone can mobilize me because it hurts, like it ends up hurting me. It never hurts me then, but it hurts me later. So you have to check your person and see, are they hypermobile in the other one? Do they have pain? So you're getting a, how do you call it? A baseline feel for how that feels. So then when you go to the hand that's injured, you can test for it. Just know that ligaments just don't tear on their own, right? There's usually an injury that tears them because ligaments are very strong. I don't care if they're short, but they're strong, especially in the wrist. They're very strong. So there's really 2 things that tend to tear them. And one is an acute injury. At some point in someone's life, there was an acute injury. The second one is through disease process. And a disease process is something like rheumatoid arthritis is the most common in the wrist, that you'll see that disease process wears down that joint and erodes that ligament. And so then all the carpal bones start to like fall away, and they're like little bowling balls rolling down the wrist, right? So ligament tears, they're definitely the harder ones to learn and to understand, but understand that ligaments just don't tear on their own. Usually the injury that causes an SL is usually a fall, but it's not just any fall. It's a fall with a twist. It's a fall with a twist, right? Sometimes people's ligaments tear when something heavy falls on their wrist. So it causes a jarring up and down, and the bones are here, and something falls on it, and it goes like that, right? And so the ligament that holds it together like breaks apart. So those are my 5 most common wrist injuries that I would, I do this with my own therapist, my own staff, and I go through these types of issues. I would say I think it is in that order because you have very specific surgeries. They're much easier to understand and to treat than your more pervasive, like, oh, you got to figure it out, problem solving. So if you have like distal radius fractures and they have surgery, it's an easy one to start to learn off of, and then you'll learn more of the complex aspects of it. If you have a TFCC injury, or even a ligament injury, right? An SL ligament injury, and they had surgery, then you can learn those protocols and how to progress them much faster. And then things like tendonitis, sprains, or that ulnar-sided wrist pain due to TFCC, those are a little bit more like, I've got to become the problem solver. I've got to become the detective to determine like what structures are injured, are at risk, or are irritated. And then once you learn what that is, then you can learn how to treat it. And it's never always there. You got to think about treating outside the box. So don't just think, oh, I have to stay at the wrist level. I actually need to move above and below. So what's above and below? Below are the fingers, below are the metacarpals. Don't forget them. Just because they don't move that much doesn't mean that they don't need a little bit of love and care, because that's where the intrinsics are. And then above that, it's like all your wrist muscles and the muscles that go to your finger all start at your elbow, dude. So if you're only like rubbing on that wrist, hoping that shit will get better, it won't. Like, you've got to go above and below. So those are my 5 top wrist diagnosis and tips, to help you think along the way when it comes to distal radius. I mean, when it comes to like wrist injuries, not just distal radius, just one of the more common ones. But if you're interested in learning more and becoming more of that independent thinker, problem solver, and just knowing exactly what to do, feeling confident about what you can do when you have like whatever type of cases come your way. I don't know about you, but all my cases are never cut and dry. They're never cut and dry. So, learning to understand more the fundamental aspects of these types of injuries will help you to understand their protocols and help you to understand the right treatments and how to progress your patients. I'm going to include the link below. If you want to come into the mentorship program, it's one of the best places to get started and one of the best places to keep learning. All right. Let me know if you have any questions. If this video has helped you, like, subscribe, leave me a comment. All right. Till next time.